Hello, everyone. Welcome to another teaching points recap. This is a great session that we have to burn some knowledge and review a lot of that we have been seeing here on VMRs. I know we can have a lot during the week, and this is a good opportunity for us to share and grow up. And today I'm here with Vale, Hans, and seeing how Vale will be the first one that will present. She's a medical graduate from Peru, and it's our great neurology nerdy that we love to learn with her. So Vale, do you want to start?
Sure thing. Yeah, I just switched my Wi-Fi. Hopefully it doesn't glitch. Okay. Yes, I'm gonna share my screen. Okay. Well, thank you everyone for the opportunity to present today on the teaching points recap session. So I'm gonna recap the teaching points of the session of the 14th of September, which the one-liner was a 46-year-old female presenting with weakness. So this was a story of a 46-year-old female that presented with acutely worsening weakness and generalized pain or paresthesias. Her story began 5 months ago, and she referred some symmetrical ascending weakness that began on her feet and ascended up to her hips, as well as paresthesias compromising both her lower extremities but also her hands. And her story progressed to the point of admission that she's now bedbound and also complains of urinary incontinence as well as dysphagia. Her review of symptoms is significant for intermittent diarrhea around the time that the symptoms began that she attributed to starting Ozempic, and her past medical history includes diabetes, obesity, and she's post-gastric bypass surgery. So to begin the session, I would like to ask you guys, when we talk about weakness, we talk about the corticospinal tract. So where along the track do you think the lesion is most likely? And you can put your thoughts on the chat if that's okay. I can give you guys like maybe 20 seconds and then I can give my thoughts. Sarah, future neurology, resident saying brain or spinal cord. Deborah saying spinal cord. Simi saying spinal cord. Great. Okay, people are kind of rooting for the spinal cord. And I think that's a great reflex thought to have, especially with a patient that has acutely bowel or bladder symptoms. I think that's an amazing thing to rule out. I think for me, with symptoms one, thinking, I was right there with you guys thinking, okay, is this in a spinal cord? Or the presence of sensory symptoms really makes me think, could the nerves be affected, right? Because usually this would also suggest the spinothalamic tract to be compromised. So I wanted to kind of take a moment to think or like to develop why this system one, or where does this system one thinking come from? What's the evidence behind it? And so most of the data that we have, or the evidence that we have when it comes to symptoms that suggest neuropathy problems versus spinal cord problems, really come from studies done in patients that have diabetes associated neuropathy. And scores have been developed from these studies that, you can see the Toronto neuropathy score, which is one that we use to screen patients with diabetes. And you can see that 3 of the 6 items on the symptom score category are sensory. And this score, when you have 3 or more of the symptoms present, the positive likelihood ratio of you having neuropathy is 6.8, which, is significant. With the caveat, of course, that these scores have been developed in patients with diabetes. And you also have the example of the Michigan screening instrument, which also has a lot of items that include sensory symptoms. And just having 2 or more increases your likelihood ratio to 3.8 to 4.7. So you would think, okay, a patient that has chronic weakness and associated to this symptom, they also have sensory complaints. This may be a point towards the nerve being compromised versus the spine or the spinal cord. However, I think that's a great thought. And the next step would be to look for the exam and see what findings kind of contribute for or against our hypothesis. So my next question for you would be, what would you look for on the neuro exam? And I can give you like maybe 20 seconds, so you can put your thoughts in the chat quickly. Okay, hand saying reflexes, strength, sensation. Brilliant, amazing. Lyra saying that she will call me. No, I don't think so. I don't think that will be necessary. Okay, great. So yeah, and actually in this patient on the VMR itself, we really didn't have a lot of data on the exam, but we did have weak plantar reflexes, which may seem like, oh, I wish we had more info, but actually can contribute a lot to support our hypothesis. So when it comes to nerve disease, absent ankle jerk reflexes bilaterally are the ones that have the greatest sensitivity and specificity for neuropathy. So when you have these reflexes absent, you have a positive likelihood ratio of 7.6. However, you can increase even more your likelihood ratio of nerve disease being the cause of the patient's complaint if you also do a thorough sensory examination, as you guys suggested on the chat. So if you see impaired pinprick and vibration sensation, your likelihood ratio can increase to 12, which means that, this patient most likely could have a nerve issue. So to summarize to this point, we have a 46-year-old female patient with past medical history of diabetes and gastric bypass surgery, presenting with chronic ascending weakness, paresthesias, urinary incontinence, and dysphagia. And her exam was remarkable for weak plantar reflexes. So, as mentioned before, the clinical presentation and the exam really make us think, oh, could this patient have a nerve issue? I'm still with you guys on the spinal cord hypothesis. To give you a little bit of a spoiler of how this VMR turned out to be, she ended up having UTI, accounting for the urinary incontinence. So the spinal cord hypothesis kind of became a little less likely. But the ascending pattern of weakness, as well as the paresthesias, really supported this being a nerve issue. And when it comes to nerve disease or neuropathy, we can really classify it by distribution. So mononeuropathy, multiplex, or in the case of our patient, with symmetric involvement of nerve areas as polyneuropathy. And beyond distribution, we can also differentiate between acute versus chronic polyneuropathy. But before we dive into the chronic category and do a thorough workup of blood and imaging and other studies, we really can narrow our workup if we do a more specific history taking and some things on exam to look for. So for this, we should really introduce the term of length-dependent versus non-length-dependent neuropathy. And when it comes to length-dependent neuropathy, that just means that the longest nerves are affected first. And the longest nerves in our body are the ones that innervate our legs. They're the ones that have the longest track to go through from the root on the spinal cord all the way down to our toes. And so usually a patient that has length-dependent neuropathy would usually start with symptoms on the toes, then the sole of their feet, then on the knees, then on the proximal part of the legs before the symptoms reach the upper extremities. And the pathophysiology behind length-dependent neuropathy is axonal injury, which also makes sense because the longest or the farthest away the axon is, the more vulnerable it is. So the farther away the toes are the ones that are going to be more vulnerable to axonal or length-dependent neuropathy. And etiologically, we can really, if we see this pattern of weakness or sensory problems, we think of toxic and metabolic causes being behind it. Versus non-length-dependent neuropathy, which usually carries demyelinating pathophysiology behind it. This means that the length of the nerve doesn't matter because all the nerves have myelin on them. So all nerves will be affected simultaneously, to put it some way, meaning that both the feet and the hands could have concomitant symptoms in comparison with axonal injury, which we would expect the proximal lower extremities to be affected before the hands are compromised. And on the demyelinating category, we have things that we, usually associate like GBS, but also systemic inflammatory symptoms like SLE and paraneoplastic syndromes. So before we dive into the world of chronic polyneuropathy, I would like to ask you, what are some reversible causes of chronic polyneuropathy that every patient should be ruled out for? And you can, share your thoughts in the chat. Maybe I'll give you like 20 seconds for that as well. Okay, vitamin deficiencies, B12, brilliant, yeah, 100%. So yeah, there are three. Sarah saying Cooper, that's amazing. Okay, so yeah, there are three main reversible, or four, I will say four reversible causes of chronic polyneuropathy that every patient should be ruled out for. Number one is B12 thiamine deficiency, and thiamine deficiency. Then the second one is paraprotein associated polyneuropathy. So you would have to work up the patient for with an SPEP and immunofixation studies to rule that out. And the third one, and the most common one, is diabetes, which is the most common cause of polyneuropathy worldwide. Okay. And our patient had a thorough workup. We can see that there's not a gamma gap that may suggest that there's some proteins increase in the serum, which, kind of makes our paraprotein hypothesis less likely, but these patients should have gotten an SPEP and immunofixation as well. We see that glucose is elevated. It's not surprising given the history of diabetes, but we also see that they did an LP, and an LP showed normal cells, but a very high protein. And you may recognize this pattern as albuminocytologic dissociation, meaning that the albumin or the protein is very, very high in comparison to the cells that are quite underwhelming. And when we have a patient that has chronic polyneuropathy and albuminocytologic dissociation, this should really be like a buzzword for thinking about CIDP. But what is CIDP? It stands for chronic immune demyelinating polyneuropathy, which is just a fancy way of saying that, the nerves are targeted in a long-term pattern. And I'm gonna talk about CIDP, covering these three main questions. The first one being, what is the primary mechanism of nerve damage in CIDP, and how is it different from the one seen in GBS? And you might have heard that, CIDP is just like the chronic version of GBS, which is, a fair comparison to make, given that the technical definition of CIDP is, immune-mediated polyradicular neuropathy occurring on the course of like 8 weeks or more, which is, it really sounds like the chronic version of GBS, similar pathophysiology. However, recent studies have shown that CIDP, more than being, monolithic disease or syndrome, is actually in a spectrum of diseases that have a variety of presentations and have also a variety therapeutic response, which, really suggests that pathophysiologically, they may have different mechanisms. And CIDP is also different from GBS because they can have a progressive pattern of disease, the one seen on our patient, for example, like progressively worsening, but it can also have a remitting or relapsing course. So you can have a patient that, it looks like they had GBS initially and then they recurred and relapse, and that also could qualify as the CIDP spectrum. Then the second question is, what are the typical motor and sensory symptoms of CIDP, and how this pattern of symptoms can help us distinguish it from other peripheral neuropathies? So as I mentioned, CIDP is a spectrum of diseases. The most classical syndrome is, this one on the left, the classical one, which is, symmetric, sensory motor, both distal and proximal nerve regions are affected, and has the best response to the standard of therapy, which is IVIG, steroids, and PLEX. But you can also have all these acronyms, don't get scared, they just stand for kind of the syndrome themselves. They can also present in a variety of ways. You can have asymmetric versions that have multifocal distributions, kind of patchy on MATSAM, or you can have MMN, which is the purely motor variant of CIDP that can look a lot like ALS and has an antibody associated with it. And you can also have more, for example, it's the one that is associated with a monoclonal IgM serum and also has an antibody and is predominantly distal. And you can have this purely sensory variant. And the caveat with all of this is that all these variants have not the best response to treatment, which really suggests that there may be some subtle pathophysiological differences from the classic version of CIDP. Okay, so the final question is, what diagnostic tests are most useful in confirming CIDP? And well, we mentioned the main immunomodulatory therapies used in management. So CIDP is a diagnosis of exclusion. You should diagnose all the other causes of chronic acquired polyneuropathy, but also you should rule out autoimmune nodopathies and paraneuropathies. And just a couple words about this. This is a new diseases that are rising up. And why is it important to think about sending these antibodies on serum and CSF? Well, because the treatment may change. As you have seen, the variants of CIDP and also autoimmune nodo and paranodopathies have a poor response to IVIG and steroids and PLEX. And this is because the pathophysiology more like involves the B cells, and that's quite complex. But the target is different, as the name suggests, it targets antigens on the nodes of Rambier, which are kind of the spaces between the myelin segments and the paranodal region. And these antibodies can be, ones that you may recognize, such as antigangliosides, anti-GM1, or the ones associated with Miller-Fisher syndrome you may have heard. However, there are other ones that are more niche. The main teaching point from this is that in every patient that you may suspect CIDP, it is recommended that you send these antibodies because the treatment may change. Because B cells are involved in the pathophysiology of this disease, some B-cell depleting therapy, such as rituximab, may have a better therapeutic power. So yeah, that's kind of everything I wanted to say about the case. Sorry, I went on a tangent on the last couple of slides, but hopefully it was comprehensible enough. So if you had any questions, I'm happy to answer them at the end. Thank you.
Thank you, Vale. I think everybody enjoyed it, and you gave a lot of knowledge for us. Hans, do you want to go second?
Yes, I can go second. And first of all, thank you to Vali. This was a really amazing presentation and so good. So now I'll start sharing the screen. Just a second. And my case goes back to October 6th. And the case presenters were Zakaria, and the case discussants were Rabi and Riza. And we had two patients, and both of them presented with altered mental status and an abnormal movements. Now, before I go into the possibilities of our differential, I would like to present a brief recap of the HBI. And patient one was a 15-year-old male. He suddenly behaved strangely with dance-like arm and leg movements. They were shown on a video to be a little bit more pronounced on the right. And he no longer talks and was healthy. And that was the main point here, healthy 24 hours ago. Patient 2 was found unconscious, intubated upon arrival in the emergency department, and he regained consciousness a week later. And then he was found to behave strangely like our first patient with abnormal dance-like movements. So we have in patient 1, altered mental status, which was acute. And in patient 2, we have an altered mental status, which was more hyperacute to chronic. For patient 1, when we encounter a patient with an acute altered mental status, we use the scan, and I like that one, mnemonic, and we may check sugar. If we have the facility, a CT scan to rule out a stroke or bleeds, then acidosis, and then we can give a Narcan just to look at opioid toxicity as well. All of this, at least in the history of the patient as given by the caregiver or next of kin, were negative. And in that case, we can then continue with our more chronic approach, which is the MIST mnemonic. And here we have the metabolic possibilities and infection, autoimmune. Is there a structure structural problem in the brain due to trauma or a mass, or maybe even an epilepsy, or are toxins involved? And I think Rabi has given us the thought experiment of transplanting one brain from one body into another. If it is systemic, like metabolic infection, then the altered mental status should improve. If it doesn't, then we have a strong indication that it's structural. Now, the physical examination of patient 1 showed a patient who was mildly tachycardic with everything else unremarkable, except for pinpoint pupils and his shaky dance-like movements. Patient 2 was in respiratory distress. We had bilateral lung crackles, and we had a pulse ox measurement of his PO2, which was 99%. Heart exam was normal. In general, both had abnormal dance-like sudden jerky movements of hands and feet. The movements by themselves already give us an indication that there could be a problem in the deeper structures of the brain, and here probably the basal ganglia. In patient 1, when we look at his constricted pupils, we get the idea of a possibility of an opioid toxicity, which causes more pupils, maybe carbon monoxide, dioxide intoxication, or a parasympathetic overshoot, but the latter we can rule out because of his tachycardia, or it is relatively uncertain. Then the other possibility for constricted pupils could be a Horner syndrome, but that is usually unilateral and not bilateral, as seen in our patient. The shaky, twitchy, dance-like movements is the next finding. And here we could consider a mass-occupying structure. Maybe the patient had a trauma, like a fall, but nothing like this was mentioned in the history. So an edema, fluid that radiates to deeper structures of the brain or the motor cortex, or the patient might have experienced a seizure of an origin that we still don't know, but we have not seen a postictal phase, and the movement was not chaotic. It was more regular or dance-like. In patient 2, when we look at his abnormal movement, we could think of the possibility of an endocarditis. Maybe he had, and this was a patient from South Africa, so maybe rheumatic heart disease hasn't been treated effectively. So Sydenham chorea would be a possibility, with emboli being sent out into the body and affecting the most vulnerable parts of it, here the basal ganglia. But our heart exam was normal. Then toxins can affect the basal ganglia, and there we have chronic manganese exposure, very likely possibly methanol, if he got alcohol from some uncertain source. Cyanide would be another toxin, carbon monoxide. These can damage the basal ganglia. And then drugs that can be purchased in the street. This MPTP was implicated with Parkinson's disease. I think it's no longer available. His bilateral crackles and the patient being unconscious makes us think about, first of all, a pneumonia, maybe an aspiration pneumonia as a very likely possibility, but we have to consider pulmonary edema, interstitial lung disease, and atelectasis are other possibilities. The lab results for patient 1 was significant for a white blood cell count of 25,000, neutrophilic predominance, platelet and HB are normal, and the urine toxicology showed methadone. And here we might have probably one culprit for his altered mental status, and it certainly will explain his pinpoint pupils. The lactic acid was 7, which is slightly elevated as well, indicating some hypoxic state. In patient 1, we might therefore narrow our differential to opioid toxicity with AMS or meningitis, which can cause altered mental status in certain circumstances. And the pathology there would be a severe meningitis causing edema, radiating on the deeper structures of the brain, the basal ganglia, which will then experience an impaired blood flow. For patient 2, we need to be a little bit more careful. Patient 2 was intubated. His white blood cell count was found to be 21,000. Everything else is normal. The PO2 in our arterial blood gas finding was normal at room air. Metabolic acidosis with elevated anion gap was found. He had a creatinine kinase of 6,000 with a BNP of 2,000, and UTOX was negative. In order to explain these lab values, we need to look at the intubated immobilized patient, and there is a possibility for demargination of neutrophils from stress. And that could explain the white blood cell count. Rhabdomyolysis is seen in virtually all intubated patients after a while, so the CK is in most cases increased. A metabolic acidosis with an anion gap is highly suspicious of a hypoxic state in the body, and the high BNP is stress that the heart might experience from hypoxia. The next stages of our examination was imaging, and the differential for, before I go to imaging, for patient 2 at this point could perhaps be narrowed to a TB meningitis involving basal ganglia that was mentioned. TB is prevalent in South Africa, so we need to consider it. Then APLS, secondary to SLE, but patient is 19 years old and he is male. Why should he have SLE? Is there a family history of clotting disease? And endocarditis, I think, can be ruled out as well. It leaves us mainly with infection and a carbon monoxide poisoning or a cyanide poisoning. Then next would be imaging, and imaging for patient 1 was found to be normal. And following imaging, the team performed a lumbar puncture, and it showed marked neutrophilia with mildly low glucose and a gram stain which was negative. Blood culture revealed Neisseria meningitis, and there we had the diagnosis from the blood culture. Now this doesn't want to work. The diagnosis then N meningitis involving the basal ganglia for patient 1. Patient 2. In patient 2, the imaging showed a very characteristic pattern. That's the reason why I thought about this case. It is a textbook sign of CO poisoning. His chest X-ray showed a pathology in the right lower and middle lobes.
The number from her.
That she didn't have.
That's that 12 actually.
Okay, and here is the chest X-ray, which clearly shows some pathology in the right lower and middle lung, and the textbook pattern of globus pallidus being hypoxic and damaged. So the diagnosis for patient 2 was carbon monoxide poisoning with severe hypoxic damage to the basal ganglia with secondary aspiration pneumonia. And this leaves me just with a brief recap of the pathology about meningitis and basal ganglia. I think I already mentioned everything. We have inflammation, we have an exudate, an edema, and this penetrates into the perivascular space that surrounds the deep arteries that provide blood to the basal ganglia. So we have obstruction to mechanical circumstances. We can also see obstruction of these vessels due to inflammation caused by vasculitis from the infection, and edema and hydrocephalus if the disease progresses even further. For patient 2, our 19-year-old, carbon monoxide binds, as we all know, very avidly to hemoglobin. Hypoxia, then as an anoxic condition for the cells in the body, affect the most vulnerable structures, here the putamen. And we have seen a bilateral necrosis and degeneration. In some instances, we can observe bleeding of white matter and demyelination of other brain areas. And I want to conclude with a brief summary of an excellent video from Profres, Hypoxemia versus Hypoxia. The difference, I think, is already clear from my presentation so far. We are looking at the capillary O2, the total of all oxygen that is delivered to the cells in the body, as being given by all the oxygen that can be bound by hemoglobin. That's the first sum. And the second sum is the amount of oxygen that can be dissolved in blood, which is a smaller, minor one. So hypoxemia, by definition, is low partial pressure of O2. Hypoxia refers to insufficient O2 available for the cells. And I think that pretty much explains everything and makes it very easy. So the question is, what does our pulse ox measure? And our pulse ox measures the ratio of oxygenated hemoglobin divided by oxygenated hemoglobin plus deoxygenated hemoglobin with 2 different wavelengths of infrared light. And CO absorbs light in a similar way as HBO. And as we all know, we might have to order a co-oximetry. The question is true versus false hypoxemia, and it is just of practical value because we have a situation where our pulse ox does not show the right P oxygenation in the blood. A lower one then actually is seen, and there is no hypoxia in the cells, and that is given by nail polish, as we probably all know. Raynaud syndrome, cold fingers is one of them, or the device doesn't work. We can have hypoxia of the cells, but a normal pulse ox reading, and that is given whenever somebody presents with anemia. Carboxyhemoglobin, CO poisoning is one possibility, and patients with dark skin, there we have to be careful. It can be all over the place. We can have a false value of our pulse ox, which is not the true one that is actually present, and that is seen in the condition of methemoglobinemia, a different kind of hemoglobin that can be either from genetic causes or from toxins, drugs that cause the hemoglobin to bind O2 much more avidly than the normal hemoglobin, which then leads to less oxygen being released to the cells in the periphery and therefore to a hypoxic state. And this then leads us to the possibility of a O2 saturation gap, and we observe it in methemoglobinemia, where the pulse ox never falls below 85%, but the calculated saturation of our hemoglobin is done from the arterial blood gas, and that can be quite normal. In this example, it is 97%. The pulse ox measured 85%. The O2 gap would then be 97 minus 85. And everything below or above 5 points towards methemoglobinemia. And with this, I want to thank for the opportunity of presenting this case. this is just a summary that CO binds with greater affinity and that we need a co-oximeter in order to determine whether a patient has CO toxicity or not. Thank you very much. And that's all the literature that I consulted for this case, an excellent video that I want to refer to. And that was a bit of a bread and butter case. Thank you very much.
Thank you so much, Hans. It was a great presentation. We learned a lot. And I think we can go with Sim. Sim, do you wanna do your presentation?
Yeah, sure, Deborah. Hello, everyone. Thank you for joining us. And I have neurophobia, so Wale, thank you so much for making neuropathy easy for us. And Hans, I really loved how you covered not only one case, but two cases for us, along with imaging and everything. So really grateful for your presentations, and I'll start sharing my screen. So I'll do a recap of case that was presented by Dr. Ravi and discussed by Jeffrey and Rabi. And it is from September 11th. So it is a case of unrelenting ulcers. So when we have oral ulcers, the question here was that what is the big deal? So big deal here was that we had a 19-year-old female with recurrent oral ulcers for more than 5 years. So when we have recurrent oral ulcers, we'll first see that what things we have to consider in such a case. So first we have to see the appearance of the ulcers, that if there is presence of any necrosis, then there might be something serious going on. Then we can see if the ulcers heal or persist, because the ulcers that usually heal are aphthous ulcers, which are stress ulcers. But if they're persisting for a long time, then it might be something serious. And we can look for systemic signs like fevers, arthralgias, or anything in the systemic system going on. So that is something worth considering. Another point here was that there was recurrence of ulcers. So when there is recurrence of anything, we can think about any underlying triggers that can be infections or certain toxins or autoimmune diseases. So these were the things we were considering here. And now we have to look for some red flags. So what would be the red flags in someone with ulcers? If there is recurrence, there is poor healing, or there is systemic fingerprint, then these are thought of as red flags. And review of systems here showed that the patient had IBD-like symptoms. There was arthralgia, alopecia, ear pain, headache, lymphadenopathy, shortness of breath, and fatigue. So we were now thinking that this is not something isolated to the mucus surfaces, but there is something systemic going on, and exam findings showed this picture, which I have pasted here. So we were now building on our differentials. So one thing we're thinking about is aphthous ulcers major, and when we have very deeper ulcers with scarring, there is something we can think about. Another consideration was Behçet's disease, which is a disease affecting arteries of all sorts and veins. And we were thinking about GI diseases such as Crohn's disease and ulcerative colitis, because sometimes they can also cause ulcers in the mouth as well. And we were thinking about GI histoplasmosis, sarcoidosis, and celiac disease as well. And when the person has involvement of so many different systems, we also think about rheumatological diseases. We were thinking about SLE, also about FAPA, which is a syndrome of periodic fever, after ulcers, and adenitis, along with pharyngitis. So that was something we were also thinking about. But also when we have skin findings, we have to think about dermatological conditions such as pemphigus vulgaris, which can cause ulcers in the mouth as well. And these were the things we were thinking about at this point. And then we were thinking that we have some surface clues, but there was a deeper mystery involved. So we're thinking what labs we can get. And here we checked for all the antibody panels, and they were all negative. And also fecal calprotectin was negative. So we had IBD-like symptoms with ulcers, but fecal calprotectin is known to have a very good negative predictive value. So it just took us away from the ulcerative colitis and Crohn's disease, and negative antibody panels took us away from many of the rheumatological diseases. And endoscopy here showed mild gastritis, and skin biopsy showed presence of granulomas. So when we have granulomas, we were just thinking that what conditions we can think of. So the differentials here were vasculitis, in which we can think about joint cell arthritis, GP, and also Behçet's disease. And there's also variety of sarcoidosis, which is known as Melkersen-Rosenthal syndrome, which presents with facial paralysis, orofacial granulomatosis, and fissured tongue. So that was something we were also thinking about. And Langerhans cell histiocytosis can also present with granulomas. So these were our considerations at this point. Then what helped us make progress further was a genetic twist. HLA-B51 was found to be positive, which has association with Behçet's disease. So final diagnosis here was made of Behçet's disease, and this is just a brief overview of Behçet's disease. So what is Behçet's disease? It is mainly a disease affecting arteries of all sizes and veins. And it is also known as Silk Road disease because it is more common in Asian population, with males being affected more commonly. It can have skin findings like pustules, purpura, erythema nodosum-like picture, and also we can have mucosal involvement with oral and genital ulcers, GI, IBD-like syndrome, and also arthritis, which this patient had. And sometimes we can have findings of vasculitis as well, and neuro. Behçet's is also a variety that Wale has taught us about, which includes basal ganglia as well sometimes, but that was not the case here. And the most common presentation is oral ulcers in Behçet's disease, but genital ulcers and other systemic involvement is also seen. And diagnosis is usually clinical, and treatment is with immunosuppression. And that was my presentation, and thank you everyone for joining us.
Thank you, Simi. It was a great review of the case. Yeah, I want to thank you all for being with us today. It was good to learn and review some old cases. We are having a lot of good reactions here. And yeah, hope to see you all tomorrow for another VMR. Bye-bye.